Say, hey guys, I'm Dr. Eric Gifford. I got Greg Gilmore here with me tonight. We're going to talk about knee pain and various causes of knee pain, what contributes, what causes osteoarthritis, and then what we can do for you to help make you better.
Yeah.
How one, what causes it, and then two, really what we can do to try to get you out of knee pain and keep you active and keep you moving. I'm at 417 Sports Medicine and Orthopedics. Again, I'm a sports medicine physician. I am a non-operative, basically non-operative orthopedic and sports medicine doctor. I am a medical doctor, and I worked at Cox Health in their sports medicine program for about 6 years before breaking off and coming out on my own. Open up 417 Sports Medicine. Greg, tell us a little bit about yourself.
I too worked for Cox before coming here. I'm a certified athletic trainer. I've been certified for over 20 years now. I don't know where that time went, but I now work with Dr. Gifford in his clinic and get to work with his patients on a daily basis now.
All right, so we put it up on Facebook as to we basically said, hey, what would you like us to talk about? We're going to do this once a week, and so we said, hey, what do you want to hear about? And I think overwhelmingly, it was a very strong response to knee pain. It's a very common problem. A lot of people suffer from knee pain, and so basically we just wanted to have a quick talk about my videographer in the background, playing movies in the background.
Fantastic job.
Stop watching Fortnite videos. So basically, we're going to just talk about what causes it, what contributes, and then what we can do to make it better. So to go into knee pain. Knee pain's a broad topic. I mean, lots of different things can cause knee pain. It can be sports related, it can be age related, it can be injury related. A lot of people, if they have an acute injury to their knee, so say an athlete sprains their medial collateral ligament, well, that takes, I don't know, how long do you think that takes to get back from?
Usually 7 to 14 days.
Yeah,
depending on the severity.
Depending on the severity, and also depending on the age.
Yes, very much so.
Young kids, they bounce right back, but as an adult, say you have a knee injury where you may tear your MCL, it may take 3 to 6 months before you're really pain free.
Yep.
So that's an acute injury. So where you have this acute sprain of a ligament. What a sprain of a ligament means that those fibers get partially torn. Well, that partial tear sometimes can make it where it's a little bit lax. Sometimes it can make it where it's completely torn and then it's loose and it has to scar back in. Well, again, that's why it takes time in order to get there. I don't have any examples of that in there.
That's okay.
But that's an acute injury. And again, if you have an acute injury, that's part of the assessment. So we bring you in, we try to determine, one, we get an x-ray, and we try to say, all right, is there something broken? Do you have a big effusion? Is there something else going on? No, okay. Yeah. I mean, we see all kinds of stuff on an x-ray. Yep. But then we bring you in, we do the exam, and we're going to determine, all right, is there laxity in that ligament? Yep. Where do you hurt specifically? Is it right there along that medial joint line, or is it, do you have laxity somewhere else? Mm-hmm. And that's an acute injury. Those happen, but usually you're going to get better from that, and it's not going to be an ongoing chronic problem.
Yes.
Well, okay. So say now you're in your 40s, and now you're still trying to run and train for a marathon, or I'm trying to train for a half Ironman, and now we're starting to have pain. Yep. Where's that pain coming from? There was no injury associated with it.
Nope. Just got out of bed.
Why am I stiff?
Yeah.
And oftentimes when you start having pain from overuse or not overuse, but just in general, age, mm-hmm. A lot of times that's just, again, it's age-related wear and tear in your knee, and then certain activities that you're doing are causing that pain to be exemplified, or I guess I'd say just exacerbated. Yeah, it just makes it worse. And again, you start to see degenerative changes in the knee. Honestly, we'll see them in people in their 30s. So it's not necessarily just 40s, 50s, 60s. Obviously, the older you get, the more wear and tear you have.
And what's wearing down, Doc? What are we talking about exactly?
So when you're talking about wear and tear in a knee, or the term I like, it's osteoarthritis. Osteoarthritis is wear and tear of your cartilage And in the knee in particular, there is another tissue layer in the middle called your meniscus. Most people have heard of your meniscus. Oh, I got a meniscus tear. Do I have to have...
That's not my cartilage?
The meniscus is a cartilage layer in between the two joint cartilages.
Okay.
So this is not well, it doesn't show the actual meniscus necessarily. Well, it says it does, but there's not one really pictured. But the cartilage of the tibia, and then the cartilage of your femoral condyle. And in between those two layers would be your meniscus layer. It looks like a little, I like to say they're just two C's and they face each other. And, like an earlobe, there you go. And it sits in between the cartilage layers of the femoral condyle and your tibial plateau. Now again, you start getting high mileage. I also like to refer to cartilage in a knee, anywhere, in any joint, kind of like tire tread on a tire. All right?
Yeah, that's good.
Obviously, if you're in a big giant truck and you're carrying a heavy load all the time, or say you're in a car and you're pulling a trailer all the time, you're going to wear your tires down faster.
Yep.
If your tires get out of alignment, they're going to wear out faster.
Yep.
If you if you're driving on a rough, bumpy road all the time, meaning you're being really active and you're really beating your knees up, they're going to wear out faster. So again, tire tread and cartilage very similar in that they're going to wear down with time. They're going to wear down with mileage. So as you start to age up, this picture shows a pretty good example of it. Is you start to get these little defects in the cartilage, where the cartilage is literally worn out, and that's what we mean by you got some wear and tear. Literally, the cartilage surface on that knee just starts to wear down. It gets thin, and in some cases, it'll start to get exposed. And now you're seeing like the bony surface underneath the cartilage.
So think of a golf course. If you've ever seen anyone chip in and they hit that nice pristine green with a golf ball and it leaves those divots, that's really kind of what we're talking about, isn't it?
You literally are missing the grass.
Yeah,
You're missing the cartilage, and now you're starting to see the dirt. Now you're starting to see the bone behind it, and that again starts to create pain. Same thing happens with your meniscus, and I think this is where a lot of people get, well, it's not necessarily misinformation because it really is there, but a lot of people will say, oh, I've got a meniscus tear. Oh yeah, I was just doing my regular routine and then started having knee pain, so I got an MRI and it showed I tore my meniscus. You didn't necessarily tear your meniscus just doing your daily routine. What probably happened was you have a degenerative problem in that knee, and so that cartilage is starting to wear down. It starts to wear down that meniscus, and yeah, honestly, you start getting over age 40 and we get an MRI in your knee, chances are pretty high and likely that we're going to find some type of degenerative meniscus tear. Now,
did you just call me a degenerate?
Just kidding. Yeah, I'll take that as a compliment. So, a degenerative meniscus tear is just more or less associated with wear and tear. An acute meniscus tear, so again, an athlete that tears, they have a knee injury where their knee gives out. They may have a medial collateral ligament. They may tear the ACL, and they may also tear the meniscus along with it.
Sure.
And so now you've got 3 different problems. And so say they have ACL reconstruction, and the MCL is going to repair itself with time. It scars in. But that meniscus, what do you do with that? Well, a lot of times we'll try to repair it. And the problem is, the meniscus in general is very avascular, so it doesn't have good blood supply, and so it doesn't always heal. And so a lot of times whenever they do a meniscus repair, they end up having to cut out the piece that's torn. And that becomes a problem because now you've got less cushioning in the knee. And so, years ago when they just started coming out with arthroscopic knee surgeries, the biggest thing was, go get your meniscus. Let's go take out your meniscus. Let's go take out. So there's a lot of people getting meniscectomies. They were taking out big chunks of tissue because that's causing the problem. Let's get rid of it. The problem was that 5, even just a few years later, 5 years later, 10 years later, those people had complete collapse of their joint space. So their joint was here at first. They tore their meniscus. They go have surgery, and now a few years later, the joint is bone on bone.
That old bone on bone. Yes. Exactly.
And so now most of our orthopedic surgeons are much more judicious with when they'll take you to surgery and when they want to consider, taking out meniscus or trying to repair it at all. And again, I want to caution people because you'll hear, oh yeah, I got my MRI, got a meniscus tear. Yeah, I guarantee you I got one. But that doesn't mean we need to do anything about it. A lot of times we can do some other conservative measures and leave that meniscus that's there alone. Obviously, in some instances, if it flips up and it's catching and it's locking your knee up or it's creating extreme pain no matter what you do, yes, by all means, you still may have to have surgery. But in a lot of instances, that's not the case.
So what can we do about it then?
So when you come in and we evaluate you and we think, hey, you've got some mild degeneration and ultimately we don't think you need surgery. I don't think you do well with an arthroscopic debridement, meaning they take out some of that tissue again. We don't want to do that.
And what are some factors that would, does age play into that? Is it just the state of your knee? I mean, what all goes into that?
So everything plays into that. So your age, if the younger you are, the less likely we are to want to go in there and manipulate stuff. Now, granted, if you're a young athlete, some things do need to be repaired, or you're causing more harm down the road by not repairing it.
Absolutely.
But again, that's a decision tree that we make when we see you and when we evaluate you and we get the imaging and we try to figure out what's the best option for you.
Sure.
But in most cases, age matters. It matters a lot. If you're too young, we don't really want to. Again, you don't want to mess with it from a surgical perspective. If you're too old, if you're 90 years old, well, you're not a good candidate for a knee replacement anymore. But I've seen it too many times where somebody comes in and they're aged up and they insist on having surgery. We have surgery and they are not able to rehab and they end up not able to walk again, and that's a horrible thing. We theoretically their pain in their knee may be gone, but then they're wheelchair bound. So we don't like to do that. So again, ages, too young, too old. Some of the biggest factors is honestly it's weight. Obviously, we have a lot of obesity in this country, and that's a very common problem. And not everyone can be thin, and not everyone can lose weight easily, and that becomes a major problem. And then that puts a lot of pressure on your joints.
Going back to that tire example that you said.
Right, carrying a heavy load puts a lot more load and pressure on the joint.
Yep.
And again. That's one of the biggest factors in what we see in arthritis and wear and tear. Okay. So age can, just the age and mileage. Certainly weight is one of the biggest factors that we have to look at. Another thing would be some of this is genetic, and when we say genetic, well, some people just have bad cartilage. Sometimes there's autoimmune, osteoarthritis as well, and then other times it's actually just the way you're built, your structure. Well, my dad was real bow-legged. Well, okay, now you're bow-legged. So we got some examples of that I wanted to show you. This one's actually well, we'll show this one first. This one, yeah, this is it. So when somebody says they're bow-legged, that basically means that the knees kind of curve to the outside. And this is a classic example. You can see these line up fairly straight, and you look over here and you can see they just curve out. They create a bow, and that puts a lot of excess pressure on the medial side of the knee. Well, the exact opposite can occur. You can have somebody with what we call valgus knees, or what we call knock-kneed or pigeon-toed. And that's the exact opposite, where the knees, instead of going out like a bow, they go in. Okay, so that's why I say knock-kneed or knock-kneed. They come in and they almost bump together.
Almost every junior high volleyball player I've ever seen. Exactly.
A lot of times this happens in adolescence, where the female pelvis, as it widens out, it alters the angle of the hips, and until they get through maturity and everything, sometimes it continues to have that angle and
Technical difficulties. Dr. Gifford will now dance for your viewing entertainment. Oh, now I was
thank God. So, now I don't remember what I was talking about.
We were talking about knock-knee.
Oh, again, this causes extreme wear and tear on the lateral side of the knees. I just had a patient, when was that? Just yesterday, the day before. She had some of the worst valgus knees I've seen in a long time.
That was the day before.
And she's been dealing with it, but at this point she's like, okay, I think I'm ready. We've been doing injections and stuff, but now I think she's ready to have surgery. But again, she made it. She's in her 60s, if not 70s.
Yeah.
And so she made it a long ways before she needed to do anything surgical.
Absolutely. And so we were moving on to, okay, so now how do we deal with that particular issue? So we've had either bow-legged or knock-kneed. We've got some degeneration in there. How are we going to treat this?
Okay. So, wait, is that what we were on? Or are we talking about what contributes to knee pain?
We were talking about the factors.
We're about done with
contribute
that.
to that.
Yeah, we're about done with that. So yeah, wear and tear,
Mm-hmm.
obviously injuries, genetics, which would be the alignment of the knee,
Yep.
and there's one other factor that I'm forgetting here. Weight. Weight was the
Yeah,
other
we talked
big
about that one. Yep.
And so what do we do? All right, so you come in, you've never had really pain before. You come in and we look at your knee and we're like, oh man, you got big valgus deformity in those knees. You've got severe narrowing of that lateral space. What can we try? Are you ready for surgery? No, we don't want to try that yet. We want to try some conservative measures and see if we can keep you from having to have replacement.
Absolutely.
So some of the things that we'll try, if you haven't already tried just regular oral anti-inflammatories, okay, so that's Advil, Aleve, Tylenol, naproxen, or ibuprofen. Those are the generic terms, acetaminophen. They now sell Voltaren gel over the counter.
Oh, that's nice.
So you can just rub a topical on there. That's also an anti-inflammatory. So if you've tried those and you've tried a compression sleeve, like an Ace Wrap or something you get from one of the drug stores or sporting goods stores.
That's the popular one, the copper knees.
Tommy Copper, Copper Fit.
That's it.
Those are just compression sleeves, and but again, those can be helpful. So if you try those things, usually you have by the time you come see us.
Yeah.
But if you haven't, we're going to start there. Start simple.
Start simple.
But then the next steps are going to be things like injections.
Absolutely.
And so if it's really sore, it's been causing a lot of pain and problems, we usually will start with something simple like a corticosteroid injection. We use methylprednisolone, or the trade name is Depo-Medrol. And what it acts is, it's an anti-inflammatory. We inject it directly into the joint. So it primarily is in the joint. There is some systemic absorption, but primarily it goes into the joint. And it's an anti-inflammatory. It reduces that inflammation around, let's get back to our arthritis picture. Yeah. I say it reduces the inflammation that's being created by these raw spots in the bone, the degenerative meniscus areas, and it just calms down the pain. Yeah. We usually combine that with a little bit of lidocaine, make you numb, make you feel good, at least when you walk out. And then the steroid theoretically kicks in within just a couple days. Yeah. So this is a pretty quick response. I've actually given myself one of these shots before. Literally gave it to myself. I was going to have my nurse do it, but she said I was micromanaging her, so she said, you do it yourself. And I said, okay, fine. Again, I did that, and my knee felt great.
That's good.
So I've had that. I've experienced it firsthand. Gave it to myself. And which means I trust it, and I'm not scared to put that in there. Some people are like, oh, steroids are bad. Well, steroids... Too much steroid. Too much steroid can be bad. Too often can be bad. But when you space it out appropriately and you don't put it too much in a certain area, it's very safe.
But keep in mind, it's because we're trying to avoid surgery at this point. We've determined this is the course of action. It's not just because we just want to stick steroids.
Very rarely do I stick this in a young person.
Yeah.
Typically it is that aging population where you're just you got some wear and tear. We're trying to calm it down.
Absolutely.
Occasionally we will put that in a young person with patellofemoral maltracking or fat pad impingement, kind of thing, because again you're trying to calm down that inflammation.
Absolutely.
But most of the time, again, it's our aging population, and the downside to Depo-Medrol or methylprednisolone is very little.
Sure.
So again, that's an injection. So there's phase one. I love an offloading knee brace. So this is an offloader. This is a substantial offloader. They make some that are a little bit less. They may only go on one side of the knee, meaning like it's just a bar on this side. It's got straps that will pull one way or the other. What this knee brace is designed to do, particularly in the realm of medial or lateral knee pain.
So the knock-kneed or the bow-legged.
This is designed to try to straighten it out. This one in particular,
I believe that's a medial offloader.
I believe this is a medial offloader for a, this should be left knee medial offloader. So what this does is there's a dial, and you can adjust how much this hinge pushes in laterally. I'm going to stand up and show you on here, because I can. All right, so if my knee was like this, so it's bowed out this way, okay? This brace is going to push from the outside and try to bring it back straight, okay? So it went from here to here.
So we're offloading that medial
We're
part.
offloading that medial joint space. So we push a little bit on this side to try to keep it straight. And again, this is a very substantial brace, and it really does a great job of trying to balance that knee out. We can do the exact opposite, if we're trying to offload laterally. And obviously they make these for right and left. So I mean, if we're having pain here, we get the appropriate brace and fitting. So sorry about that. All right, so that's another thing. Sometimes we try a much simpler brace, such as just a regular econ hinge knee brace. Sometimes we'll try just a simple compression sleeve. There's lots of things you can use, and that's kind of our first line of treatment.
Sure.
Also, physical therapy, rehab.
Do some simple exercises. Yeah.
There's a lot of things you can do to try to strengthen some of the muscles around the knee, also muscles of the hip that can contribute to how the knee bends and how you stand. You mentioned adolescent females, or all the junior high volleyball girls. Their knees kind of go in when they jump and land, and that's a very common injury mechanism for ACL tears.
Yes, it is.
And so a lot of times we will try to train them to, hey, look, we got to keep that knee in a straight alignment. It doesn't necessarily need bracing, but we got to strengthen those hips. We got to strengthen that vastus medialis. We got to strengthen these muscles that will help those knees stay straight. And
can I interject here? One person did ask a specific question. Jeanette asked earlier for exercises to avoid hurting your knees. And in general, what you're trying to do is not do activity that involves you moving through your entire range of motion with your body weight. So you think about most of the major workout systems at this point want you to do squatting. And squatting is a great activity if your knees don't hurt. So you need to be incorporating activities that don't require your full body weight on your bending knees. So things like laying on your back and doing bridges, or unweighted muscular strengthening activities. So side lying, firing your rear end and bringing your leg up off the ground. So anything that doesn't require that you have your body weight and move through that entire range of motion is really what you're looking for there.
I say that's really difficult to describe without really going through it with someone. And a lot of times we will prescribe physical therapy.
Absolutely.
We'll set you up with say a certified athletic trainer, or sometimes we'll send you to a physical therapist clinic and let them really show you some of the things that can benefit your posture, benefit your the mechanics of your knee, your hip, and your ankle.
Absolutely.
And because that can be very helpful as well. So anti-inflammatories, compression, offloading knee braces, occasional simple injection. All right, what's next? Well, where do we go from there? Well, say the corticosteroid didn't work, or it worked, but it only worked for 6 weeks or so, and then you're right back where you started. You're still having pain.
Happens.
Well, so then the next things that we have, we have, these are hyaluronic acid injections. This is a gel 1. This is called Euflexa. These are synthetic joint fluid that we can inject into the knee. What it does is it lubricates the knee. It also upregulates your body's healthy production of its own lubrication. So basically, putting this in there helps the knee recognize, hey, that's good stuff, and try to produce more. The problem with these is they're expensive. Okay, and obviously everyone's insurance nowadays doesn't always, a $3,000 deductible. Well, that's if you need bilateral knee injections, that's going to chew into that deductible. That's a lot of money. But again, when you've tried other things and you're still thinking towards surgery, this is still a great option.
Still better than getting cut off.
Exactly. Medicare covers these. Great. The problem is your private insurance, our regular insurance for employed individuals and cash pay, all that kind of stuff. It's expensive. So that's a tough. It's just a tough situation.
It is.
We also have some regenerative techniques. I brought in a couple of examples. We do platelet-rich plasma.
So when you say regenerative, are we regrowing our meniscus?
So glad you asked that. I think there's a big miscommunication or misinformation.
Yeah.
Okay. Whenever we're doing a regenerative treatment, we're not going to regrow new cartilage.
What?
That's what they said on TV.
I know.
That's what I read in the magazine on the airplane, although there's no more magazines on airplanes.
Yeah.
But I remember I used to see those ads all the time in the American Way magazine, and they'd show a before and after x-ray of their regenerative treatment. Again, I think that's just clever marketing, but not necessarily a truth. What you're doing is you are creating a little bit of a healing response.
Okay.
And so I like to say, just like if you got a cut. So say you got a cut on your arm, or just an abrasion. What happens? Well, your blood, it's bleeding, starts to aggregate. So you start to get platelets there. It starts to clot. Once that starts to clot, they immediately start releasing growth factors. Okay, so that's all these cellular signals that tells your body, one, to stop bleeding, and two, to fix it. And basically you're going to grow new blood vessels, you're going to grow new scar tissue, and it's just going to create that healing response. Is it going to be good as new? That's why you see scars. Because it's forming a fibrous scar tissue. It's not necessarily making it perfect like it was before, but it's going to scar in, and it will have some remodeling over time. So when we talk about regenerative medicine, we're trying to use something. We have various tools that we use, but we're using a regenerative treatment mechanism to trick your own body into healing itself. So when you get into a chronic degenerative state, such as this, I mean, you've got your cartilage is thin, your meniscus is all roughed up, it's been like that for quite some time. Your body's no longer trying to create that healing process in that area. And what we're trying to do is trick it into saying, hey, let's get this to heal up. Again, are we going to grow new cartilage? Are we going to get rid of bone spurs? No, it's not going to do that. It's not going to have that effect. All these bone spurs that form around the outside. I think I got another picture here of bone spurs. Thought I did. Yeah, here we go. So when you get these, we call these osteophytes or bone spurs. Again, a regenerative treatment is not going to have any effect on that. It's not going to dissolve those spurs and make them go away. And honestly, if you went in there and surgically removed all those, they'll come right back, and they usually come back with a vengeance. They come back worse than they started. But this is just another picture showing the erosion of that cartilage. And so what we're going to try to do with regenerative treatment options are create a little healing response. We're going to create a little fibrous scar tissue, over that raw irritated surface. It's going to have, if there's cellular signal pathways to create a little tissue healing. And again, a little tissue healing is a big difference than saying, oh, I'm going to grow all new cartilage. Again, we're not going to try to advertise that, and anyone that is frankly false advertising.
So we're trying to fill back in the divots, basically.
Yeah, we're trying to, you're putting a little coat over it.
Okay.
That's good. And here's another thing that people advertise. We can do this, and you'll never have to have surgery. Well,
I don't like the word never.
Never say never. You never say 100%, never say never. And truthfully, even if we're doing some regenerative techniques, I mean, we can do the most expensive regenerative process they have. You're still going to get, a mild healing response, which may get you out of pain, may get you back, able to use things and move things and do really well for a while. But eventually, you're going to wear back through that, and then you may have problems again. If we get 3 to 6 months out of it, we still think that's successful. If we get a year or more out of it, we think that's great.
Really successful.
And so, when you do those treatments, we don't necessarily expect you to get long-term permanent relief. And eventually, it will wear to the point where you may still need a surgery. But this is the regenerative stuff I'm talking about. So we use platelet-rich plasma. It's where we can draw your blood. This is a vacuum container. It draws 12 cc's of blood. We then spin that down into in a centrifuge, and we're going to get a concentration. This is a little wax layer here. We're going to get a concentration of plasma, what we call platelet-rich plasma, right above that separation of the red blood cells, the little wax separation layer, and we can extract that and then inject that into the tissue area we're going after. Greg, you just had one of those.
I had one in my hip.
Let's say you were having quite a bit of pain in the hip. We said, hey, let's try one of these. Let's see if we can get you some pain relief. Now, you were pretty mad at me for a few days.
We were not friends.
It was sore for a few days, but then it's been doing well.
Yeah.
We haven't run yet.
No.
We're still on the resting from activity, but again, we're getting there, and I'm hoping that we can have, again, a little bit of a healing response. That was the whole idea of that.
Absolutely.
And we want to get you back running. Half marathon win?
Oh, not anytime soon.
Oh, not anytime soon. Okay, all right. 5K? Come on.
Maybe I'm not allowed to run yet.
I'm saying, what's your goals?
Oh, I'd like to do another half again at some point.
All right. Maybe the Bass Pro next year. We can all do it together.
There you go.
All right.
As long as Jen goes too.
Yeah. As long as I promise not to run out in my underwear. All right. So the other types of PRP that we have, this is called the
step
Lysone.
up from.
This is just a little step up. This is very basic. It's not exactly giving you an extreme concentration. This is a Y cell kit, and we have one that we already spun down. We already pulled the PRP out of, so all that's left in here is platelet poor plasma and the red blood cells on the bottom. But it's going to show you that you can see that when you spin it down, we're going to extract this layer right here.
What is in that?
That is the platelets and the growth factors.
Okay.
I mean, that is what we're going after. So it's that separation of the layers, and then we get in there, we take that out, and then we go in and inject it into your whatever tissue we're going after, whether it's a knee. We also put this in tendons or any other joint in your body. So that's PRP or platelet-rich plasma. This is another really neat new technology. It's not necessarily new, but it's only recently been approved. We have this is called Fluid Flow. It's made by Biolab Sciences. This is actually placenta derived. Okay? So what they're doing is they're taking donated placental tissue at C-section deliveries. So these are moms that sign up way in advance. They have all kinds of testing done on them. And in a controlled environment and a scheduled C-section, they then will donate their placenta and umbilical cord to science. And then this company is taking growth factors that they're pulling from the placenta,
which is growing a human being,
which grows a baby in 9 months. So obviously the placenta is very rich in growth factors in tissues, and we can inject that into various areas. So hence the knee. This is actually covered by Medicare. So traditional Medicare plans will actually cover this, and we have to make sure that we dot our I's and cross our T's and make sure that we do the right things in order to get it approved and make sure that we're doing it appropriately.
Which we would have to do with one of these too. It's all required documentation.
Those are all the steps we always take every day. But this is being approved by Medicare, which is a really amazing thing, because instead of just putting in a steroid, which is again very effective in some cases, we have some other options.
Absolutely.
Obviously, these are options, and this is a really exciting option
Absolutely.
to create a little regenerative process. And so that's something I'm super excited about. Again, more for your Medicare population. But the regenerative, products that we have, the platelet-rich plasma and all that kind of thing, honestly, the younger you are and the milder your degeneration, the more successful those treatments are. Why? Because the degeneration is not as bad. You're not trying to fill in a giant pothole. You're just trying to smooth the road.
Well, and I'm assuming your immune response is probably better too when you're younger.
You're more apt to heal everything. And so again, you can't be too old or too young to have any type of regenerative treatment. And we're pretty excited to be able to offer that here. We do PRP, platelet-rich plasma, starting at $300 a joint, which is very affordable, comparatively speaking, to some of the other programs around town or nationwide.
Well, and you're an expert in osteoarthritis and in orthopedics, so that makes a big difference.
Makes a huge difference. There's a lot of clinics around town and around the country that really don't specialize in musculoskeletal at all.
No.
And they're sitting here advertising, we'll put stem cells in your joints. And you're like, have you even done a joint injection before? Now, granted, they obviously learn on the fly, but we've been doing this I've been practicing this is my 7th year, fellowship trained in musculoskeletal sports medicine.
It's kind of a big deal.
It is, and ultimately we don't want to do something that's inappropriate. We want to make sure we're treating you with the proper technique, the best thing for each person's scenario.
Absolutely.
But that's something we're really, really excited about. I lost my place. Where are we at? Me my cue cards.
Jen, have there been any questions that people have submitted?
Is anyone other than our children watching this right now?
Oh.
Yes, all right.
All right.
All right.
Well, thank you.
Well, if anyone's watching, if you have any questions specifically, just let us know. I mean, type it in right now. We got somebody on the computer right behind us, and they're like, hey, don't forget to do this. Don't call me, call him.
Yeah, no. Don't call me either. Send it in through Facebook Live.
Let's see. Couple other things that we do specific to knees, and I've talked about this in some other instances. This is called iovera, and what it is, it uses cold to transmit the cold through a needle tip and then freeze a nerve.
Sounds scary.
No, it's actually we numb you with some lidocaine, and honestly, we've done this on a lot of people that really don't complain about the process at all. The
No.
worst part is the numbing.
Yeah.
Okay, and that's the worst of it. Just kind of like going to the dentist. Nobody likes that part. But
Sure.
then once you're numb, usually you don't
It's
feel
fine.
anything.
Yeah.
But this is a great little device we can use. Honestly, we use it for perioperative pain control. So patients that are going to have knee replacement,
Okay.
you
So
can numb those.
beforehand.
You can numb those nerves around the skin.
That's great.
And then they tolerate they get out of the hospital quicker. They rehab much faster, and they basically just use less narcotics.
Yeah.
And that's a great
option.
thing. We
Yeah.
also use this in other joints. We can ablate different nerves in the shoulder, the suprascapular nerve specifically for people with real bad arthritis. We can go after the deeper nerves of the knee for patients that are not surgery candidates. Again, sometimes that's too young, too overweight, too old, all those different things that make you a non-candidate for surgery.
Sure.
Diabetes, just certain other health conditions.
Sure.
And so there's a lot of people that would be a good candidate for something like this, but it's typically after we've tried other things. This is something we would go to, and that's just another technology that we offer here at 417 Sports.
So we've talked about several different kinds of injuries. We've talked about several different ways we can help treat them. Who should they come see about it?
Us, of course.
Oh, yeah.
I'd say if you go straight to a surgeon, what does a surgeon do? Well, they operate.
Yeah. That's,
and it's nothing against surgeons. We
No,
send people to surgeons all the time.
They're necessary, absolutely.
But they tend to have this looks like a surgical candidate, let's do surgery.
Let's cut on that.
Yeah, and so again, we like to give you all the options first, and by all means, if nothing works or we've tried other options and surgery is the best option for you,
Yep.
by all means, we're going to send you to surgery.
Absolutely.
And that's important. But again, who do you come see first? Somebody like me.
Yep.
Do you want to go see a walk-in clinic at the grocery store?
No.
Probably not, because
No.
they're not going
That's
to
not
have
what they specialize in.
No, they don't specialize in musculoskeletal care.
No.
If you got a cold or a runny nose or a rash or something, sure, that's great. But
Absolutely.
for really having problems with a knee or any other joint, we come see us.
Yeah.
And again, I was with Cox for a long time. Obviously, we have Mercy here in town. We like to approach things a little bit differently. We're
Yep.
very personal.
Yep.
The front desk is only like 5 feet from me,
Yep.
and so there's no disconnect when you call
No.
into the office. You get almost a quick and immediate answer. We're going to follow up with things very rapidly and quickly because there's not that loss in the big group setting.
Yep.
The Bone and Joint Center. When you call up there, everyone calls the same number.
Yep.
Who answers that? I don't know. I never knew who answered it. I was there for 6 years. I still didn't know who answered the phone.
No.
But here, we answer it.
Exactly.
Greg answers it. He
It's
comes
usually-
and he walks right around the corner and says, "Hey, Gifford, what do we do with this?" And I say, "Let's see him, or let's do this. Let's try that." And that's one of the great things about an independent private practice like this is
Yep.
we're small enough that we can still really give attention to detail and really take care of the patient specifically.
But why should they come to you as opposed to a chiropractor, doc?
Whew.
Because there's a lot of, and I'm not picking on chiropractors, but there's a lot of places in town that offer these same things. Why should they come to us instead of go there?
So again, I think it comes down to the specific training and experience that we have.
I see.
Again, I tell people to go to chiropractic clinics for certain things. I say,
Absolutely.
hey, you do good well here, go over here, go over there. But when it comes to like regenerative techniques in a joint and various places, again, who's got the most experience with that is somebody like myself and there's lots of other sports medicine providers like myself in town. But ultimately, we're trained for this specifically. We treat non-operative orthopedics. So we look at a knee and we're like, yeah, we can do something here to make this better. And again, we are the experts in that field. We don't want to sell you something you don't need.
Nope.
We don't want to send you to surgery when you're not ready. We want to do anything we can to try to get you back at being active, doing things like you want to do without considering surgery or without being misled. There's just a lot of misinformation out there.
So basically, you want to give them all the information and help them to make the best decision possible for them.
Honestly, I think that's what I probably do better than anybody. I like to explain to you exactly what's going on in your case. So if you come in and everyone's different. Everyone has a different story. Everyone has a different activity. Everyone has a different injury. Everyone has a different background.
Yep.
Everyone has a different job.
Yep.
And we take all that into account and make a plan for you. This is not just a standardized, oh, we use this for you, this is it. No, we're going to say, well, these are your options. This is your insurance situation. Sometimes that matters too.
Sometimes it does.
And I pay close attention to that. And
Yeah.
I'm very much so paying close attention to
Yes.
that. The deductibles are sky high,
Yes.
and when it's going to come out of your pocket, I pay attention to that.
And we have cash options that are sometimes honestly better than using your insurance, believe it or not. I
True.
know it sounds crazy.
Well, when you got a $3,000 deductible,
Yeah.
it may be cheaper to just do a cash pay visit with us, and we
Absolutely.
have that option.
Yeah.
Whereas at the big hospitals,
No,
it's
not so
insurance, and we're going to bill you until your deductible's met and until your wallet runs dry.
Yeah.
That's not how we're going to do it. We're going to treat you right, and we're going to make sure that you're doing the right thing for you, and it's also cost effective. That's a very important point.
Absolutely.
We have some great cash options that are we're up front with it. We're like, this
Yes.
is how much it's going to cost. That's
Yep.
it. I don't care what we do. This is what it's going to be.
Not one dime.
Yeah.
And there have been instances where we have tried to do something for someone that didn't work, and we have eaten the cost of the more expensive thing.
That's
because
true.
that was what was best for the patient.
Say
It happens.
And occasionally we're out of something, and that patient came from far away to do something. We're going to do what's right for the patient. We're gonna go up a notch and be like, all right, let's do this. Let's get it done.
Because like he says, the three people that operate in this office are the ones you're going to talk to on the phone and deal with everything else. So we want you happy with what you are getting. So
Exactly.
that's very important.
What else? What are we missing? Any questions over there? Make something up. Come on, give us a question. Jeez. I'm putting my camera person on the spot. My camera woman, also known as my wife.
Yep.
Let's see what else.
So if you do need to get a hold of us, you can always look up our website at 417sportsmedicine.com. You're always welcome to give us a call here at the office, 417-771-3147. You can also email us, info@417sportsmedicine.com.
We've had people that don't talk on the phone and
Yeah.
only correspond through email.
Yep.
Either
That's
way,
fine.
we are happy to talk to you whichever way you need to talk.
Absolutely.
If you can't figure us out on Facebook, then I don't know how you're watching us on this. But whatever.
That would be me. I would be that person. How do I get in this?
I feel like there was something else I wanted to touch on, and I'm drawing a blank. Anything else from questions that you had?
We talked about regenerating knees. We talked about what to do as far as the osteoarthritis end of things. The exercises we didn't get real hot and heavy into.
That's
I'll
a
see if I-
whole nother animal.
Yeah, we'll probably have to address that more specifically. Honestly,
Yeah.
Take a time.
We
to
could
do
do
that.
We could do a full therapy session in here like that.
Yeah, I'll have to. We'll have to wear a short.
Absolutely.
No, those are the main questions as far as the knees went. I think we covered those from.
Okay.
From
And if we didn't answer your question and you still are on the fence on, well, my doctor told me I got a torn meniscus, what should I do? Come see me.
Yeah.
Again, I will shoot straight with you, and I'm not going to force anything on you. I'm just going to say, hey, this is your options, and if I were you, this is what I would do.
Yep.
But at the same time, it's up to you.
Yep.
And again, I'm just going to help you make an informed decision.
Yep.
And that's honestly, I think that's our best quality here is we really try to inform you and help you make the best decision on each individual scenario.
Because we live here too. He lives right down the road. I live in Nixa.
I will find you.
Yeah, we we want you to get better so you can impact the people in your community. So that's part of the reason I enjoy working here. I'll be honest.
Anything else? We're good. We're happy to evaluate you if you need us. We'll be doing a video next week. I'm not sure what our topic will be. Maybe shoes.
Ooh,
Sounds exciting.
Shoes and foot pain.
Yeah. We'll do some shoulder pain. We'll do some therapy type stuff, and just some exciting things in the future. And we'll go from there. All right. So that's it from us. Thanks for joining in tonight. Or if you join in later, just to watch, what you can do for your knee pain. Again, don't forget to like our Facebook page. Shoot us a message anytime you want. And we'd be happy to take care of you.
And who are you?
I'm Dr. Eric Gifford.
And I'm Greg Gilmore, and we're with 417 Sports Medicine and Orthopedics.
And should we do a dance? Is there a jig on here? No.